the right inhaler. Choosing the right inhaler. I'd like to say I have no conflicts of interest to disclose, and we'll just move on from here. So are we prescribing the right inhalers for our patients? As you can see, there are a lot of them. And this isn't even the updated version. So there's a few more to add. But this question is not about the medication in the inhaler, but whether or not the patient has the correct technique and enough inspiratory effort. And why is this important? Good inhaler technique is essential for a patient to receive the intended dose of medication. The speed of inhalation, inspiratory, which is inspiratory flow rate, or their negative inspiratory force, can have a significant effect on the quantity of drug delivered and thus clinical efficacy. And as we always know, education is key. Quite often, inhalers are considered easy to use so that patients do not receive adequate training, even though it has been estimated that up to 68% of patients do not use their MDI or their DPI correctly. Two things about this slide. Sometimes that number, depending on which literature you read, can be a lot higher. And so that's really disheartening to know that close to 70% of our patients with inhalers out there aren't using them correctly. And then for you guys out there who aren't clinical, what is an MDI or a DPI? And we're going to touch on that real quick. An MDI right here, if you can see my arrow, this is a meter dose inhaler. And right here, this is a Respimat inhaler. And different inhaler devices require different techniques and speed of inhalation. So these meter dose inhalers and Respimats, they need a slow and steady inspiratory effort. And then also with a meter dose inhaler, consider using a spacer device. And you can see this spacer device right here with the meter dose inhaler attached to it. We're not going to talk about spacer devices today. That could probably be an entirely different echo on how it helps with the deposition of medicine into the lungs. But we're going to move on to what is a DPI. All right, a DPI, here's a couple of examples of dry powder inhalers. You have your Trelegy Ellipta, you have your Spiriva HandiHaler. And a dry powder inhaler needs a fast and forceful inspiratory effort. And this is where we're going to start to get into what we're going to talk about today. If the peak inspiratory flow rate is less than 60 liters per minute, the patient may not achieve optimal clinical benefit. And a different delivery system, such as a meter dose or soft mist inhaler, which is the Respimat, or a nebulized therapy, should be considered. So as you can see, if we bounce back up here to this slide, there are a lot of different inhalers. Which ones are MDIs and which ones are DPIs? So there are 10 dry powder inhalers out there. And if I kept flipping back and forth from that first slide to this slide, most slides are listed as Advair Discus, Brio Ellipta, Tudorza Pressair. So there's 10 different dry powder inhalers out there, and those are going to require a little bit more effort from your patient. So, and I think to keep it simple, always keep it simple, for the sake of this talk, basically powder or no powder, okay? Now we're going to talk a little bit about inspiratory flow. Along with proper education on inhaler technique, how do we know that our patients have the correct amount of inspiratory flow to achieve optimal delivery of their inhaled medication? Studies show that a third of hospitalized patients prior to discharge for an exacerbation have suboptimal peak inspiratory flow rates less than 60 liters per minute. So we may be discharging these patients with inhalers that they can take, but they may not be getting the optimal delivery of their inhaled medication. So one way, and this is what we're about to get into, and it's something I've really wanted to introduce to the APHP, the Appalachian Pulmonary Health Project, at some of our quarterly meetings in person. So we'll choose to do it here on the echo. This is an InCheck Dial. It's an inspiratory flow meter that can be used with an adjustable dial to simulate internal resistance of dry powder devices to assess whether a patient can achieve an optimal peak inspiratory flow rate of at least 60 liters per minute. And so some of you guys out there, respiratory therapists or people involved with pulmonary rehab, you may say, well, what about the NIF manometer? I think that we all know that there's ways to possibly cheat the NIF manometer by using some of your, pulling your cheeks in. But the NIF manometer does not help you train a patient on how to use their inhaler. So the InCheck Dial is ideal for children or adults having difficulty understanding proper technique. It identifies the inhaler type, the resistance, and the corresponding optimal flow rates. This also trains a patient to achieve optimal flow rates in a matter of minutes based on their inhaler. And I am going to do, in a few minutes, I'm going to, share my screen, and I'm going to do a demonstration with this so that you guys understand exactly how the InCheck Dial works. But you're going to be taking, a big deep breath in, and there's this wheel. If you can see my mouse here, there's a little wheel, and it's going, when the patient takes a breath in, you're going to be able to see what their inspiratory flow is. So I'm going to go to the next slide. Here's a few different pictures of, what this graph is showing down here on the InCheck Dial. So not only are we going to be able to see what their inspiratory effort is, we're going to be able to train them. As I said earlier, with your MDIs and Respimats, you don't want just a super fast, forceful breath in. That is a slow and steady breath in, and it needs to be between 20 and 60 liters per minute. All right, and here's your green range for your dry powder inhaler. You have 30 to 90, and that's going to be based on the inhaler and the resistance that it provides. So you can see that if you were looking inside the InCheck Dial, this is what it looks like. It has different holes to simulate the resistance of the different types of inhalers, and you can see that the meter dose inhaler and Respimat is this nice big open hole for you to take a nice big deep breath in, and these other holes just continue to get smaller with their resistance. So this is just some literature that comes with your InCheck Dial. You can see the different levels of resistance. And so you actually have, you can see right here, these guys are low, and then it just starts to creep up from here to medium, low, medium, and then the highest are going to be this Easy Haler and your Spiriva Handy Haler. All righty. And so then there's these great pictures on the side, so it helps the patient match their inhaler whenever they're choosing the resistance flow. We'll go to the next slide. Just kind of a repeat of the slide that we were just at. Great pictures trying to help a patient match their resistance flow. And then down here you can see where it talks about dry powder inhaler values between 30 and 90 liters per minute are generally associated with clinical efficacy. Meter dose inhalers need between 20 to 60 liters per minute. And why we want to take that slow, steady breath is because a lot of that medicine will just go straight to the back of our throat, or we could possibly swallow it. That's a whole other echo as well, talking about proper inhaler technique. And even though that Handy Haler does have the highest resistance right here, it does require only 20 liters per minute to be associated with clinical efficacy. The next slide is just another reiteration of a different study that was done based on the different inhaler type. The red value is insufficient flow, which is your inspiratory flow, your negative inspiratory force. Yellow is flow rate that could be improved, and green is associated with that's optimal. You're going to get the right amount of medication And then gray is just your flow rate is just too high. And some of you guys may be thinking, especially with COVID, how are we going to use this? Does every patient get their own InCheck Dial? And the answer is definitely no. There's two ways to keep your patients safe. We're going to use a one-way valve inspiratory mouthpiece, or you can use bacterial and viral filters. I would have to say that the one-way valve inspiratory mouthpiece is going to be the most economically friendly for your pocket. And it's definitely effective. There's no way that you can blow into the device. You're sucking, you're inhaling. So now I'm going to go to my demonstration. Mithra, help me. How do I unshare? Yes. Oh, stop sharing. Okay.
Perfect. Yep.
All right. How are you guys doing? Everybody on board here? So.
Yes, ma'am. Thank you. Right.
So this is the InCheck Dial device. And I hope that you guys can see it okay. And here's this little wheel that we're going to be making go back and forth, okay? And basically, and here's what the inside of it looks like. And I have it and it looks like everyone can probably see that. And I have it on the least amount of resistance right now. So I'm going to go ahead and put my one-way inspiratory valve, and I have this lined up. And you can see on here, it talks about the amount of resistance. So especially if you have your literature from your InCheck Dial that was on some of the slides, it's really easy to line that up. All right. So pretty much you just pound it on the back of your hand and it resets a magnet. I'm going to go ahead and exhale completely. Took a big deep breath in, and you can see the wheel went all the way past 120 negative in liters per minute. So I know I'm doing good with that. So now what I'm going to do is I'm going to reset it, and I'm going to move it to this guy, and there's an arrow that matches up. So this one is, you're talking about your breezhaler, which is not an MDI, which is not a dry powder inhaler. But why I'm doing this and showing you guys each amount of resistance is because this is not as easy for our patients as we think it is. Okay. So now I'm going to exhale completely. So taking a really nice deep breath. I do not have lung disease. I was only able to get that up to 75 liters per minute. Okay. So I'm going to reset the dial. And now I'm going to go to a medium low resistance. I'm going to exhale completely. I'm going to give it the best shot that I have. Okay. So I really did give it a good shot, because I've got that up to 85. All right. So I know I have enough inspiratory force to take that inhaler. Now I'm going up to your yellow zone. I should probably have my paperwork out, which is going to be your medium. I'm going to exhale completely. And I'm taking a really good breath in, and that I only got that to 65. I'm going to go to your medium high resistance, reset, just pounding it on my hand. It resets the magnet, pushes the wheel back down. I'm going to exhale completely, and I can see that I've got my arrow is lined up with this flow. And I am really giving it a good shot, and I only got that to 60. Okay, I'm going to reset it. I'm going to go with the highest resistance. And if I were to take my, you can see where the highest resistance, that's a really small hole. Pop that down, exhale completely. And I got that to 45. Okay. So, part of this talk is to make people aware that a lot of our patients can't do this. And we're not necessarily assessing not only do respiratory therapists, especially in pulmonary rehab, get to do a lot of inhaler education, but how often are we saying, can you even take that inhaler that you've been prescribed? And then the other way to do the training, so let's say that I have, I'm using my meter dose inhaler and I think I'm doing a great job, and I come on here and take a big deep breath in. Well, you know, and I went past 120 liters per minute. This is how you would use this also as a training device to teach people to slow down, that their goal is to get it in here between this 20 and 60 liters. So you're going to exhale completely. And we're going to teach them to slow down. And me even thinking that I'm slowing down, I put it up to 55. So then you would just repeat that education, pop that down, have them try that again. Slow, steady, deep breath in. And I kept that around 45, 50. Okay. So this is the InCheck Dial. I'm pretty excited about it. You can clean the outside with an antiviral, antibacterial wipe. And then you can also just, pull your one-way valve out, and it should be clean enough and ready for your next patient. And I guess I can stop sharing my screen unless anyone would like another demonstration with anything.
Thank you so much, Lisa. That was a great demonstration. You did a wonderful job, and we really appreciate it. Thank you. Did anyone have questions? Sorry, Lisa, what was that?
I was going to say there's a couple more slides on here.
Oh, absolutely. So if you wanted the little green upward arrow button at the bottom that says share screen. Yep. Okay. Perfect.
And so now when not only are we going to see, do these patients have enough inspiratory effort, but we're going to train them how to use their inhaler with the InCheck Dial. And basically this is just kind of reiterating what I just said. Since my, if people were just going over the slides, you're going to explain that you're going to check how the patient uses their inhaler, and you're going to set the dial to represent the patient's inhaler. So you just find the pictures of their inhaler or the names and match them up to the resistance chart. You're going to insert a disposable mouthpiece and ask the patient to inhale as they normally would using their inhaler. And that's after you've done the whole making sure that they have what their regular inspiratory effort is without any resistance being added to them. Then you're going to show, after they show you how they would normally use their inhaler, you're going to show the patient where the wheel stops relative to the range for their inhaler. Then you're going to reset it and you're going to repeat it. And this time you're going to ask them to inhale gently or forcefully based on what their inhaler is. Then we're going to coach them to match their inspiration technique to the zone for their inhaler. And then we're going to allow them to practice enough to feel what the right inhalation rate is for their inhaler. And I do have my references down here for you guys. And so some of you may be wondering where I learned about the InCheck Dial, and this is being used in a few hospitals that I know of in their COPD readmission reduction programs, where the respiratory therapists go to patients that have had an exacerbation of COPD, and they're checking their inspiratory, their negative inspiratory force prior to discharge. And then they're rechecking it 10 days later when they come into their outpatient clinic to see where they're at and make sure that the patient is using their inhaler correctly. Because sometimes we forget a lot of things that are being given to us when we're in the hospital and we're ready to go home, don't we? So there's the end of my presentation. Does anyone have any questions about the InCheck Dial or anything else?
Thank you again, Lisa. We really appreciate it. Any questions from the group, feel free to unmute and just chime in. Thank you.
Lisa, this is Brandi Bell.
Hi, nice to see you back.
Thank you. This is the first time I've heard about the InCheck Dial. I'm pretty intrigued by it. I think Dr. Donahue, our pulmonologist, would be too. I see that you have like disposable mouthpieces for your patients, and you just share the main device, but is the main device fairly expensive, or where did you purchase yours from?
That's a great question. I purchased mine right when I got back from Utah before COVID hit. And I would say with about 10 inspiratory mouthpieces, that one-way valve that's going to block anything going into the piece of equipment, and the InCheck Dial itself was maybe around $130. So it's going to be your initial purchase of the InCheck Dial, and then purchasing the inspiratory, the one-way inspiratory valves after that. And that's going to be your most economical way to go, is the one-way inspiratory valve. In the hospitals, they're not using filters. They're just using, for us, the purple top wipes that kill everything. They're wiping it down between patients and using the one-way valves. So, but when I did Google that exactly how much was everything, I think it's going to be, where are you able to purchase from? Are you able to purchase from Amazon, or does it have to be through McKesson? Just whoever's your purchaser is going to depend on the price. It's pretty all over the board when I look online, but I think ours, and like I said, that was it basically in like January of 2020. It was about $130 for the startup package.
Thank you.
Yeah, I'm pretty excited. This was something I wanted to present at our little quarterly meetings and see if that was anything that you guys were interested in. Sometimes for me, and maybe it is just me, I like the NIF manometer, but sometimes I don't trust it as far as did they do it right? Did they use their cheeks? Because that they can just do that and then all of a sudden it's off the charts, and there's not a lot of, it seems to me, like continuity with it whenever you're getting results. So for me personally, I'd like to switch to this. But thanks for your question. I knew that was going to come up, but it's relatively inexpensive.
Do you use inspiratory muscle trainers as like any education with your patients?
We do.
Okay.
We do.
That's what it kept reminding me of when you were changing the inhaler, how the diameter kept getting smaller.
Mm-hmm. Yeah, and for some reason I can't, those inspiratory muscle trainers that you're talking about, I can't get my hands on those anymore. I don't think they make those. And I really liked them because you could plug them up with oxygen, and your patient could be doing their training with oxygen. The ones that I use now, you can't do the oxygen at the same time, unfortunately. So yeah. Any other questions? Anyone else out there has seen the InCheck Dial or used it before? Nope. Well, I hope that everyone's as excited as Brandi Bell is, because I am.
You should be a salesman for the company, Lisa. I'm ready to go talk to my accounting department right now.
That's awesome.
Lisa, I'm not even a clinician and you got me excited about it.
Right. Well, we have to make sure that the stuff we're prescribing they can take. And if you look at their, if you go back through the presentation on that very first slide, there is this inhaler chart. And on that inhaler chart, it talks about Advair discus, Brio ellipta, the Trilogy ellipta, the Tudorza Pressair. So the name of the device is at the end of it. You just have to know, is that a dry powder inhaler or is it not? But then there's some great other options, like for Advair, they do have an HFA MDI, so that if you know that someone does best with that medication and they can't take the dry powder inhaler, there are other options for certain medications, so that they can get that medication and have a meter dose inhaler, which is a little bit easier, and you can train them with their spacer device. So it's just knowing really that chart, and then being able to come back to this talk, and then setting them up with your Brandi Bells out there in the world to use their InCheck Dial and get tested. Make sure you have enough negative inspiratory force.
Lisa, I will be attaching your PowerPoint in the recap email, so everyone will have a copy of your slides with that chart as well.
Great.
Any
Dr.
other-
Doyle?
Dr. Doyle, yeah.
Yeah.
I went ahead and put my comments in the chat since I'm at this computer that has that mic and I forgot to bring my earphones. How am I doing right now? Brandi, can you hear what I just said? Yeah, okay. Thanks.
Yeah, I would stay right there, Dr. Doyle.
Okay.
Don't move.
So I have a case, and in a way, this case starts out as a question for Lisa, but I warned her on what she was going to be seeing. So, but I just wanted to mention that our turnout today is really great. We have 4 Grace Ann Dorney sites, 5 of 9 APHP sites, 2 sites in Pennsylvania. Stacy Stewart, if I recall, you're in Ohio?
That is correct.
And I think you're a federally funded Black Lung Clinic, aren't you?
Yes, I am.
Okay, so that makes Krista Mastel happy to that we have 4 Black Lung Clinics on this, and Krista regularly participates, which I really appreciate. And then I noticed, Mitra, that a couple people came in late, Stacy and Dean, and I just wanted to give them a chance to introduce.
Absolutely, that's a great idea, Dr. Doyle. Thank you.
And Dean, I think you have a new CEO, and if you would mention that, it would be great.
Yeah, I'm at Pocahontas Memorial Hospital, and this is Dean Gunner. I'm the cardiopulmonary director here, and we do have a new CEO here, and his name is Andrew Baer. And that's all I've got going on today. Thank you, Dr. Doyle.
And Stacy, actually, she was able to chat me a little earlier when she logged on from Genesis Black Lung Zanesville. So Stacy, if there's anything else you wanted to add in, for sure, you're more than welcome to. Dr. Doyle, I think that was everyone for intros.
Okay, and then I want to make an important announcement now, and then we can go into the case. But Appalachian Pulmonary Health Project, with all our Grace Ann Dorney Pulmonary Rehab members, have our annual respiratory therapist and CEO meeting next Friday, not this Friday, but next Friday, October 16th at 10 a.m. I'd like to ask the RTs to make an effort to bring your pulmonologist. We have more pulmonologists in the network now. Dean, I know you've got a pulmonologist. Brandi, you've got yours. And I'd also like to ask you to get your CEOs to come. So, and the format might even be, is it 10:15 is the time, Brandi? Oh, October 15th. Thank you. Friday, October 15th. We might even ask, I think what we're going to do is not have 2 separate meetings, but have us all meet together, keep it to an hour, since people are more likely to come to a 1-hour meeting than a 2-hour meeting. So that's the announcement about that. And now if I could share my screen, I want to go ahead and show you the cases.
Dr. Doyle, I made you co-host, so you should be able to share screen now.
Okay, great. Can you see that?
Yes, sir, we can.
Okay. And Brandi, I know I can count on you to tell me if you can't hear, so wave your hand if you can't hear. So what you see here at the top is just basically one of the ways I get med students to learn how to read spirometry is a little tic-tac-toe thing, where if you look at the very top, the upper left-hand corner is the absolute or crude value of the FVC, then the FEV1, then the ratio, and then our percents predicted, and then percent change if they had bronchodilators. And these are 2 cases of people who have severe COPD. And so I wanted Lisa to comment, and then underneath I put what inhalers are currently prescribed. And a really important habit for us is not to say that I have learned from Lisa preparing this talk, is not to say they're on a Symbicort inhaler or they're on a Advair inhaler because all that tells you is the drug. I've learned from Lisa that an inhaler has two parts to its name. It has the drug and it has the equipment. So in the case of Advair, Advair is the brand name of the drug, but Discus is the equipment. And Lisa's teaching us to consider not just the drug, but the drug and the equipment being used. So that second word, whether it's Combivent Respimat or albuterol HFA MDI or Advair Discus, is drug plus equipment, kind of like one of those Latin names for a tree, Quercus stellata. It has the genus and the species. So what you have here is a 60-year-old male, and you can see that his ratio is 37%, and his FEV1% predicted is 34, and most of us know that that means severe obstruction. And then you can see that he had little or no post-BD, post-bronchodilator improvement. And the other patient is a 67-year-old woman, and both of these people, these are PFTs that we did here at New River in the past 2 weeks. So if you're doing a lot of PFTs, it's not rare to see people with severe obstruction like this. The second person, as you can see, has a ratio of 45%, and her post-BD FEV1% predicted is 45%. She had a little bit of improvement, but not enough to be considered significant post-BD. On her, we have lung volumes and DLCO, and her total lung capacity at 74% means that she has mild restriction. So actually, she has a mixed ventilatory impairment of both obstruction and restriction. And she's on a Symbicort HFA. I think that's enough, or actually, I think I left something out. She's on a Symbicort HFA. And what's the equipment, Lisa, with Symbicort?
When you look at the name of the Symbicort, it doesn't talk about it being a meter dose inhaler.
Oh, that's right.
But
Yeah.
it, you know, most of those L-shaped inhalers like this are meter dose inhalers and are easy to use. So
So then I'm going to let you be the first discussant on this case, and other people, these two cases, others can chime in. So when you look at this, what do you see, and what concerns do you have for one or both of these people?
Well, both of these people need pulmonary rehab. And both of these folks have not had any type of inhaler training. I would say that they both need to come in and see what their inspiratory force is, but just off the cuff, I would say that patient number 2, the 67-year-old female, is probably on, you know, if she hadn't had measurement of her negative inspiratory force, that the Symbicort is a great medicine for her to be on. And when we talk about patient number 2, he would definitely need to be brought in with inhaler education and need to find out if he had enough inspiratory force to use that Discus. And if Advair was a medication that was working really good for him, but he did not have enough inspiratory effort, then they could switch to the Advair HFA.
Yeah, and I want to spell out that for people who are, remember what Lisa said at the beginning, we're talking about two basic things: dry powder inhaler, which takes more inspiratory force, and it's a fast inspiration. Just like when we do PFTs, we want people to blast out, get their forced expiration. In this case, they need a forced fast inspiration to get that dry powder inhaler in. And so the first guy is on one of the hardest dry powder inhalers to use. Lisa and I looked at this. We think Spiriva, what's the equipment on Spiriva? The Spiriva.
Spiriva comes in 2 forms. It comes in a HandiHaler, which has the most resistance. You know, it's that you put a pill in, you crush the pill, and you have to be able to get the pill out. It has the most resistance, but they do say that about 20 to 30 liters per minute, it will get that medicine out. But it is one of the more difficult inhalers to use. But Spiriva does come in a Respimat, which is considered one of the easier ones. Now, if anyone's ever had to train a patient on how to use a Respimat inhaler, you'll know that the inspiratory effort is easier, but learning how to use that inhaler can be a little tricky, and how to jab that, you have to puncture a hole in that little, Brandi, I see you shaking your head, so maybe you can help me with this. I've lost my words. But that's a hard one to put together, I think. So you really have to find out what your patient's capable of.
And then I think after the Spiriva HandiHaler, Advair Discus is one of the hardest dry powder inhalers that requires the greatest inspiratory force.
Actually, it kind of goes, Advair is that medium low, and then we go into our Brio, and then you have like your Asthmanex Twisthalers, which is the medium high, and then the high, you had the HandiHaler, and there was another one out there.
Okay, I had it backwards. Then Advair is at the low inspiratory force requiring end of the dry powder inhaler.
Mm-hmm.
Okay, good. So this isn't as bad as I thought.
Nope.
Any other comments on these patients, Lisa, or anybody else, or questions about these patients?
I'm like Lisa, how she mentioned, they have to be able to generate that force, physically. But a lot of times our patients are taking 15 other different medicines, and they've always taken like an MDI, and then all of a sudden they're prescribed a DPI or one of the twist ones, and they're super confused on how to use it the right way. It's sometimes it's not even that they can't generate the force, which I feel like we fixate on a lot. Sometimes I think it's confusion with how to use different inhalers and how to start using this new one the right way. I've had people come in, I swear, that take Spiriva and are like, yeah, I'll just take this pill, swallow it every day. And I'm like, no. And these patients, they're like, I'm not breathing any better. I don't know why. Well, you're not taking your breathing medication properly. So sometimes, it's not about generating the force. I think sometimes, like you said, Lisa, it's just education. And, just because, the pulmonologist starts them on it and goes over all this education on the inhaler, sometimes patients will drop the ball and not get it filled for 2 or 3 months because they feel okay, and then they'll start back again, and then they just tell a pharmacist, oh, I don't need any education, and then they've forgotten how to use it, and most of the time they won't ask a question. You have to come right out and have them show you how they're using it before sometimes you can find that they haven't been using it correctly.
So Mitra and Elizabeth, we got another person, so be nice to have her introduce herself.
That sounds good, Dr. Doyle. Amy Livingood, we saw you just logged in here. We just usually go around as we do intros here, so everyone's familiar with one another. We wanted to see if you wanted to introduce yourself to the group. You are muted right now. No worries at all. You're more than welcome to chat in as well if you prefer that.
So I consider it a very special occasion, if I heard this correctly, that we have a WVU resident with us, and I think she said internal medicine, Vida Falahatian, and I guess I hope she doesn't mind me asking her this, but I never learned any of this stuff about inhalers when I was a resident, and I'm curious. Vida, what, if it's right, if you are internal medicine, and what year, and is this brand new to you, or have you heard some of this already?
So I'm a general preventive medicine, not internal medicine resident. It's my first in this program, and I had the 2 years background in prelim general surgery residency, and I have never learned or taught anything about how to use those experiments and stuff in detail.
And Dr. Doyle, so we, with Project ECHO, we're actually doing collaboration with some of the occupational medicine residents and the GPM medicine residents over at WVU. So that's why we have a few of them joining in on some of the sessions we have, but we're really excited to have them on here.
What's GPM?
General preventative medicine. Is that correct, Vida? Correct me if I'm wrong.
Yeah, it's general preventive medicine residency. It's a 2 years program residency. And in addition to that, you have to have like a 1 year as like internship in medicine or surgery.
That's all I have, Mitra and Elizabeth.
So I'm really excited at our turnout today, and now I've just made life more complicated for you guys because we knew that we needed inhaler education and that it's a lot easier for our patients to take a pill versus an inhaler. And I know, Brandi, I'm sure you've seen your patients whip out their inhaler and do 2 quick puffs right there during class, and that's just not the way to take it. So please send your patients to your respiratory therapist for inhaler education, and we'll do our best to be able to monitor their inspiratory effort and see if they're on the right medications and help make suggestions for you guys.
Thank you, Lisa. And Dr. Doyle, I see you raised your hand.
Grace Ann wears many hats, but often in national and probably international forums, she brings the patient's perspective. And if you're there, Grace Ann, I'm sure people would be interested in the patient's perspective on what Lisa was talking about.
Well, Dan, for years, it's been clear that physicians prescribe inhaled medications and assume that patients can learn either from their pharmacists or elsewhere how to use the medication. And Lisa is quite right to underscore as many as 70% of all patients do not use their medications properly. So a key element for pulmonary rehabilitation is inhaler training. And it's suggested, I'm on a group now that's revising the guidelines for pulmonary rehabilitation. And it's clear that in places like let's say Australia, where they have updated their guidelines for PR, that a key element is not only to teach in the proper technique for each inhaler, but to reinforce it at each session, to ask patients to demonstrate which inhaler they're using and how they use it. And I think that what Lisa has presented today is very, very important, because doctors do not have the time or really the knowledge base to educate their patients and to be sure that they're using it properly. So Lisa has teachable moments. She sees someone use albuterol as a rescue inhaler and use it improperly. That really is the time to stop and review. How do we use a rescue inhaler? And really we have the same medicines for the last 20 to 30 years, the same chemical compounds. They have just been, the way the pharmaceutical companies are making money these days is putting them in ever new jazzy devices that require different inspiratory techniques. So this was a very valuable presentation. And from the patient's view, there is no point getting a medicine that costs several $100s a month and not using it properly, because you can't assess the effect of the medication on the patient.
Thank you so much, Grace Ann. That's great input. Thank you all so much. Were there any other comments or questions from the group before we launch the poll here? Alrighty, well, again, big thank you to Lisa for the awesome presentation and demonstration there. It was really wonderful. and really sparked some great discussion there. And thank you, Dr. Doyle, as well, for preparing that case and that tic-tac-toe demonstration as well. It's really wonderful. We appreciate you both very much and appreciate all of you for joining the sessions as always. So thank you all very much. I'll go ahead and launch the poll and then get into our announcements for next time. Anytime you all finish the poll, feel free to leave the meeting. So we'll see you guys next time. The only announcement that I have is that our next session is on October